Good evening. Hi, you have just tuned in to our Basics of Emergency Medicine for Dental Facilities. And as you see up on the screen, Dr. Stanley Malamed and myself, Dr. Don Cohen, will be presenting. We thank Health First, who sponsor us, and now we'd like to begin our lecture. And before Dr. Malamed, I'm going to jump on this for only one reason. So for all of us who practice dentistry, we've all lived with this phrase. Well, you're about to hear the whole gist of when, where, and how from the man who really came up with this phrase, Dr. Malamed. Go for it.
Don, thank you. And good evening, everybody. So let me go right to work. With the first slide, basically saying that, hey, these things do happen. We're talking about medical emergencies. They can and do happen in the practice of dentistry. So let me just start out with a definition. What exactly would we call a medical emergency in the dental office? And quite simply, we're dentists. We hopefully enjoy doing what we do. We're busy working in a patient's mouth. So a medical emergency would be some kind of an event, unforeseen event, that makes you stop doing the dentistry because all of a sudden your concern is not the tooth you're treating, but the patient's life. The patient's life appears to be in jeopardy. Do they occur? Well, of course they do. And this is an article I had published. It was published way back, almost 30 years ago, 1993 in the ADA Journal. It was a survey of 4,307 dentists in North America, every state in the US and 6 provinces in Canada. Long story short, 95% of these doctors in the survey said that they had experienced at least one medical emergency in their dental practice in their career. And a total of slightly over 30,000 emergencies were reported by these 4,300 doctors. This is the list of emergencies, the whole gamut here. Syncope, fainting, by far the most common, a little over 50%. But everything, angina, seizures, asthmatic attacks, low blood sugar, cardiac arrest, any medical condition, any and all medical conditions appeared in this survey. So if you do the mathematics, and we have 30,000 medical emergencies, we have 4,000 doctors in the survey with an average career of about 14 and a half years. That works out that in your 14-year career, you will have 7 emergencies, or what that boils down to is simply one emergency every 2 to 4 years. The first article referenced here is mine, and 2 articles from the United Kingdom from 2012 and 2014, all basically showing the same thing. That if
Dr. Malamed, can I throw in one? So here's one. We at Health First have over 40,000 emergency medical kits out on subscription. We've discovered simply by tracking that there's an event on at least 3% of these every year. So I think if you put them together, they're going to track the same way. And yeah, the fact is, this happens.
As they say, stuff happens. This is for Viva. Somebody just put a question up saying that there was no sound. I am not sure if that's true or not, but I'm going to keep going, okay? So yes, one emergency every 2 to 4 years. So the next part of this is, as a doctor, whether we are dental doctors or medical doctors, what is our obligation to this person, whether it's a patient, a person in the reception area, the victim? And this is what I get involved, fortunately or unfortunately, with a lot of medical malpractice, lawsuits brought against dentists for various reasons. And when it does involve a medical emergency situation, and by the way, I do defense about 95% of the time, I always ask the question, what is the obligation of the doctor to that person, the victim? And this is what I say. Our obligation is to try to keep that person alive until they either recover or until another person who is more qualified than we are takes over responsibility for that treatment. So that leads us then into our discussion for today. and that is, how do we prepare? Well, there are 4 items, 4 steps, and we'll go through each of these: basic life support training, preparing a in-office emergency response team, emergency assistance, and finally, emergency drugs and equipment. Basic life support training, number 1, and it is absolutely, hands down, the single most important step in the management of all medical emergencies. Now, basic life support, as you see right below it, it has other names, and it's commonly known as CPR, cardiopulmonary resuscitation. I could easily substitute CPR as the single most important step in managing all medical emergencies, but that gets very confusing because the mental image people have of CPR is doing chest compression. And that's not really what it is. It's a combination of steps. So I'm going to call this, we're going to go over the steps in just a little while, but we're going to call this from this point on basic life support. Now, I showed you a list of 4 items. If my 4-item list for preparation became a top 10 list, basic life support, the importance of basic life support is such that it would represent the top 7. It is that critically important. So I'm going to go now with an assumption, because most states, as a dentist, to maintain your license every 2 years, essentially, you have to show a currently valid CPR card. This is also true for dental hygienists. In some states, it is also true for dental assistants, but in no state is CPR, basic life support training, required for front office people. And my recommendation strongly would be that every office out there make it mandatory that every person who work in that dental office, whether they work in the back with patients or in the front, be required to be trained in basic life support. So number 2 on our list is setting up a team, setting up a very basic, rudimentary in-office emergency response team. And it all boils down to having a plan before the problem happens so that people understand what to do. So we're going to talk about a very simple team of 3 people. Now, most offices have more than 3 people, which is going to make it a little bit easier. But let's go back to a small dental office. It's a younger doctor just starting out in his or her practice, probably has an assistant and a receptionist. We have a 3-person office. Member number 1, going on the assumption again that everybody in that dental office is trained in basic life support. Member number 1 of the team is the first person there. So if this is the doctor's patient, this is the doctor. If this is the dental hygienist patient, this is the hygienist. And if this is somebody in the reception area who collapses, this is the receptionist. And their job is stay with the victim and yell for help. It has to be an emergency code, if you will, but call for help. We're not making a phone call for outside help. We're activating the in-office team. And that person will stay with the victim and administer basic life support as needed. Member number 2 of our team, on hearing that call for help, before they go to where the emergency is, gets the stuff. What is the stuff? The emergency drug kit, the portable oxygen cylinder, and the automated external defibrillator, the AED, and brings them to the site of the medical emergency. So now we have other people. We have member number 3, and actually 3, 4, 5, 6, and on. Once the doctor arrives at the scene, he or she is now directing the resuscitation, the treatment of the patient. So what else can be done? Other persons in the office can monitor vital signs. They could assist with basic life support. If it's thought necessary to activate emergency medical services, one person goes and makes that phone call. If you work in a multi-story building, one of your staff members goes down to the lobby of the building to wait for the ambulance, being certain that the elevator is there in the lobby. You might want another person to prepare the emergency drugs for administration if drugs are going to be given. And if there is another person, have them just stand in the corner of the room and keep records. Keep a timeline. What time the phone call was made for 911, what time the ambulance arrived, what the vital signs were. So this is what, again, these are the other tasks that can be performed. All right, so the next number 3 on my list is calling for emergency assistance. And that's really interesting because when do you call for help? And quite honestly, it's a feeling in your gut. It's a feeling in your gut that, well, number one, I don't know what's going on. Something is wrong and I don't know. Okay, another one is I know what's going on and I don't like it. All right, when you, the doctor or the person in charge, feel you need help, do not hesitate to call for help. I have been, yes,
Dr. Malamed, let me jump in. One quick one on this one. Not only never hesitate to seek help, never think that maybe you're going to be embarrassed because it wasn't necessary. It is always better to go for it and make sure that that help will be there. And then later on, okay, it was cool and a patient did fine all by themselves. Certainly, certain situations are like that, but don't hesitate.
Absolutely. I mean, I don't have the time to go into it, but there are several occasions where I've been contacted by a defense attorney to help a doctor when an emergency occurred. And after hearing the story where the doctor felt in his mind, I can handle it, and it turned out they couldn't. Getting help, never hesitate. If you think you need it, it's a feeling again in your gut. And who do we call? Very, very simply, in North America, 911. Outside of North America, numbers may be different, but 911 in Canada, 911 in the United States. And keep in mind, our obligation as the doctor is to try to keep that person alive until they get better or until somebody comes along who is better qualified. Now we're talking about emergency medical services, the EMTs and the paramedics. Okay, what is their job? Their obligation is to keep that person alive, stabilize that person's condition, and if necessary, transport them to the hospital for definitive care. A couple of interesting studies. This might be of relevance to a lot of you out there. It's the response time in the United States for an ambulance, urban, suburban, and rural. So the first article by Brooks in 2019 covered the New England area. Response time from phone call being received to arrival on the scene in an urban area was 9 minutes. In a rural area, it was 15. The 2017 article by Mel covered the entire United States. In an urban area, response time of the ambulance was 7 minutes. Suburban was 6. Rural was 13. However, in 25% of the rural emergency medical services, the response time exceeded 19 minutes. Just keep in mind that you, the doctor, are going to be with that person, whatever the emergency may be, trying to keep that person alive. And in some cases, it might be it's not always 7 minutes. It's not always 13 minutes. It could be 20 minutes or longer. And this is rural, but let's look at a picture from a urban area. If you're waiting for this ambulance to arrive in your dental office, it's not going to be there so fast. Okay, so you got to keep that in mind. Training becomes very, very important, which leads us then into the fourth of our items, emergency drugs and equipment. Okay, so if there are doctors in the audience, and I presume there are, if you have a permit in your state or province to do general anesthesia or parenteral sedation, which is essentially intravenous sedation, and in more and more states to administer oral sedation, many state dental boards now have regulations that require you to have a determined by the state dental board, you have to have certain drugs and emergency equipment. So if you are that doctor, and you'll see the list that I'm recommending for all dental offices in a moment, I will guarantee you the drugs that I talk about are in your emergency kit. The only difference would be that if you're doing intravenous sedation or GA, there are many other drugs that are related to the process or the practice of giving GA or IV sedation. Now, most of you don't. Most of the doctors probably listening to this do not use sedation. Yeah, they do. Inhalation sedation, nitrous oxide oxygen. Okay, we use that. We use local anesthesia. And if that's the case, there are only 2 states, Massachusetts and West Virginia, that do require you to have a mandated list of drugs. But for the other 48 states and the District of Columbia, there are no requirements. So let's take a look at Massachusetts. Massachusetts on the left in 2010, West Virginia in 2015, made it mandatory. Essentially, if you practice dentistry in the Commonwealth of Massachusetts or the state of West Virginia, here is a list of the drugs that you have to have, drugs, by the way, and equipment that you have to have in your dental office. And that list from those 2 states is the list you see in front of you. Okay, so I've had a textbook on medical emergencies. The first edition was in 1978. It's now in its 8th edition from 2022. And over these years, what I call the bare bones basic emergency kit in my book has changed. It started out in 1978 as 15 drugs. So I would be out here saying to you, doctors, every one of you, whether you are a oral surgeon, periodontist, general dentist, pediatric dentist, here are 15 drugs that I believe you should have. The problem with that is I'm an anesthesiologist. I'm a dentist anesthesiologist. And of those 15 drugs, 3 or 4 of them had to be administered intravenously. Well, I started teaching in 1973 at the University of Southern California, and I retired 40 years later, 2013. And it's a fact that most dentists don't start IVs. In fact, I just finished this last weekend. Today is Tuesday, and I just finished a course up in Portland, Oregon on intravenous sedation. And these are doctors who've been in practice for 10, 15 years, some of them. Never, ever done an IV in their life. So I learned rapidly that, no, having intravenous drugs mandated doesn't make sense. So my list went from 15 drugs down to about 4. And then asthma started getting more common. Drug abuse, the opioid epidemic occurred. So my list is now 8 drugs. So what I would like to do is go through these 8 drugs with you. I just, there we go. See, why can't I get my, there we go. So we start out with 2 injectable drugs. First drug is epinephrine, known as brand name, known outside the United States by its brand name adrenaline. And to my way of thinking, this is the single most important drug we have in emergency medicine. It's used for one reason. Actually, it's used for 2 reasons, but the main one in red is anaphylaxis, the life-threatening allergic reaction. Anybody out there in the audience who has a bee sting allergy, a peanut allergy, or any kind of a severe allergy to food or drugs, you carry with you what is called an epinephrine autoinjector, anaphylaxis. The other reason for using it is bronchospasm, and bronchospasm is the actual, what is actually happening during an acute asthmatic episode. The airway narrows down. And in fact, bronchospasm is a component of the anaphylactic reaction. So the drug we talk about, and again, the drug which you absolutely need to have in your office is epinephrine. Now, there are many different versions of epinephrine, but in all of the versions, what you need to have in your office is what is called an auto-injector. So what you're seeing here on the right side of the picture is the OVQ. And what I like about this, you've heard of the EpiPen. The OVQ, it actually talks to you. Now, I'll come back to that in a moment. There are 2 concentrations of epinephrine, and drugs are administered based on the patient's body weight. So for the adult patient, and by definition, an adult patient is a person who weighs more than 30 kilograms in body weight. 30 kilograms, to translate it into pounds, is 66 pounds. So if a patient weighs more than 66 pounds, the adult version of epinephrine, which is the 1 to 1,000 concentration, is administered. If you are treating children, and if the child weighs up to 66 pounds, the pediatric form of the drug, which is more dilute, the 1 in 2,000 concentration, is used. And if you have a dental office where you treat both adults and children, you need both, whether it's the OVQ or it's the EpiPen for adults, EpiPen for pediatrics, you need both. Back to the OVQ. Why I like it is the fact that it actually talks you through using it. Once you pull the cap off of it, it'll tell you, first of all, we'll talk about where to give the injection, but it tells you when to give the injection and how long to keep it.
Contains no needle or drug and is for training
Oh,
purposes
there we
only.
go.
Do not use this trainer during an allergic emergency.
Okay, so I think Don did that for me, but it will talk you through the actual process of giving it. Now, the only other injectable drug in our bare bones basic kit, and this is a drug that you're more likely to use because happily, anaphylaxis is something that is very rare in a dental office environment, but non-life-threatening allergy, itching, hives, and a rash do occur. And the drug we use for this is diphenhydramine. Diphenhydramine, by far the most common brand name, of course, is Benadryl. It comes as a 50 milligram per milliliter single-use vial, ampule, and it's a very, very safe drug. So let's talk about let's talk about these two drugs. Okay, let's talk about epinephrine and the diphenhydramine. And unfortunately, this slide is not going to show up the way I wanted to, but the place where we give as a dentist, where we're going to be giving either the epinephrine syringe or the diphenhydramine injection is called, the muscle is called the vastus lateralis. It is the muscle on the anterior lateral part of your thigh. Now, unfortunately, the picture, the diagram, the cross-section on the left-hand side of the slide is, you can't see the entire thing. Anatomy. The reason this is chosen is 3 reasons. Number one, compared to the deltoid muscle. Now, the deltoid muscle is where those of you who got COVID vaccinations, the upper part of the arm, the mid-deltoid area. This leg muscle is more vascular than the deltoid muscle. Number two, it is easy for somebody to self-administer the injection in their leg. Much more difficult to inject yourself in the deltoid muscle. And number three, the deltoid area has a lot of anatomy. You know, once that needle penetrates the skin and also in the mouth, of course, mucous membrane, the injection's blind. And the thing that we don't want to do is to take a needle and damage a nerve, an artery, or a vein. This muscle, the vastus lateralis, is nothing but muscle. No anatomy of any importance. So there are 3 reasons that this is chosen. It's more vascular, therefore the drug works faster. Anatomically, it is very, very safe. And number 3, you can administer it to yourself without any kind of a complication. So this is, again, the only place that we should consider the administration of one of these 2 injectable drugs. Now we have 6 drugs that are non-injectable. And the first of these is our bronchodilator. A bronchodilator is used to treat bronchospasm. All right, bronchospasm is, as I said earlier, the actual clinical term for what is happening in an asthmatic attack. The airway narrows down. The patient is having difficulty getting air in and out of their lungs. The drug of choice, a bronchodilator, in the United States, primarily, there are others available, but albuterol is the drug. The same, that's a generic name, interesting. And yet, for most drugs, generic names do not change from country to country, but this one does. Outside the United States, albuterol is known as salbutamol. And some of the brand names here in the United States are ProAir, Ventolin, and Proventil. And it's a very, very safe drug. There are no contraindications. If you're not asthmatic, if you just inhaled it, if your airway is not in bronchospasm, nothing's going to happen. It's a very, very safe medication. And I did that same thing again. I will learn how to do this eventually. Something relatively new. The inhaler on the left, the orange device, it has an aerosolized powder. The albuterol is a aerosolized powder. And when you put it in your mouth and you inhale, you activate it. A lot of that medication doesn't get down into the patient's lungs where it has to work. If you look into the patient's mouth, a person's mouth after they use the inhaler, you will see a lot of white powder on their palate and on their tongue. And given the fact that in children, the size of their tongue is larger in comparison to an adult, less medication gets in. So it has been always recommended that pediatric asthmatics use this device you see in front of you called an inhaler, called a spacer. And what you do here is you put the spacer on the right-hand side of the picture in your mouth. You attach the inhaler orange on the left. You activate the inhaler, which then is diluted down. The medication is diluted down in that chamber, and then you breathe in. And what simply happens is a lot more of the albuterol gets into the patient's lungs. This is now being recommended for all asthmatic patients. All right, let's move on then to the next drug, and that is a vasodilator, a drug which opens up arteries. And it's used for angina or angina, one or the other, okay? Both pronunciations are correct. And that drug is nitroglycerin. All right, nitroglycerin comes as tablets, as you see in the right-hand side of the screen. It's also available as a spray, nitrolingual spray, but the cost of the nitrolingual spray, quite honestly, is prohibitive. And I would venture to guess that of the however number of people are actually listening to this program, virtually every one of your patients who has a history of angina has the tablets. You need nitroglycerin tablets. It comes as a 0.4 milligram per tablet. It's again used to manage an anginal attack. It is also used to manage a suspected myocardial infarction. Now, again, given the limited time we have here tonight, we're only discussing preparation of the office. We're not really going to be getting into the management of specific medical emergencies. But there are two indications for nitroglycerin, angina, and the pre-hospital management of a suspected myocardial infarction. Sugar. Gotta have sugar. Sugar to treat hypoglycemia. Hypoglycemia is low blood sugar, and most likely to occur in a type 1, perhaps a type 2 diabetic, but more likely a type 1, the insulin-dependent diabetic. It's also not a bad thing to have available for the macho 18, 19, 20-year-old who faints during an injection. Okay, syncope. Syncope occurs most often during injections. The way you treat syncope is you lay the patient down supine in a dental chair, and they wake up, they recover consciousness, and they're sweaty, that's diaphoretic, they just feel weak, they feel nauseous. Oxygen is good, but also sugar. They may not be hypoglycemic, but you know what? Sugar is good.
You know, Dr.
Yes.
Malamed, another key place on the glucose. Very often, that macho guy who passes out, but we tend to see a lot of our teenagers who are doing 2-a-day, 3-a-day practices, and they got to get to that dental appointment. They just got to wait 3 months, and mom isn't going to wait for the juice or the oranges and whatever. And sometimes you'll see that kid literally start to sort of go woozy and maybe even half pass out in your office. what a great place to have something before they're unconscious to be able to get some glucose into them.
Right. Excellent. So again, what I'm showing here are some options also. We have the orange juice, we have the non-diet soft drink, and some, as you see in the right-hand side of the slide, some, in quotes, medical version of sugar. And of course, any of these things which are going to be put in a patient's mouth are only going to be used in a person who is conscious. Unconsciousness is obviously a contraindication to anything liquidy going into a patient's mouth. Thrombolytic. Thrombolytic is a fancy name. Well, we're going to use a thrombolytic drug for a suspected myocardial infarction. A myocardial infarction, which sadly is called by too many people a heart attack. Let me just go off on a tangent right now about that, okay? Because that term heart attack is used improperly most of the time. It actually is describing two very different things, apples and oranges. A cardiac arrest, person is unconscious, no breathing, no pulse. They call that a heart attack. But then they also say when somebody is conscious and having chest pain, they're having a heart attack. Very different. Very, very different. Totally different. So using the correct term, in a myocardial infarction, your patient will be in the chair. He or she will push it. They're lying down in a relatively supine position. You're doing your dental treatment. They're going to push your hand away and sit up. And you're going to say to the patient, I'll be the patient, Stanley, what is the matter? And I'm going to say to you, Doc, it feels like there's an elephant sitting on my chest. It feels like there's a boulder on my chest. Okay, that is usually the first symptom the patient will present with when they're having a myocardial infarction. What has happened is a blood clot has formed inside one of their coronary arteries. A thrombus, a blood clot. A thrombolytic agent like aspirin is part of the pre-hospital management of a suspected myocardial infarction. Aspirin, whether it's chewable aspirin, chewed and swallowed with water, whether it's an aspirin tablet, keep in mind that if a person is allergic to aspirin, and there are people who are, we don't do it. But this is a very important drug. And the reason it's important is that it is possible today to survive a myocardial infarction with little or no permanent damage done to the heart muscle if that person gets into the hospital's emergency room and up to the catheterization lab rapidly. They can do what's called a primary balloon angioplasty to reopen the artery. Aspirin prevents that blood clot from getting too big. And then this procedure has a better chance of being successful. Okay, let's then talk about the newest drug in the emergency kit. And I have to be honest with you, I am a consultant for Health First Corporation, and I'm under medical advisory board. And Don, I don't know how many years ago it was when you came to me about, we're thinking of putting an opioid antagonist into the emergency drug kit. And an opioid antagonist is used for an opioid overdose, a narcotic overdose. And I was really not a proponent initially, because I do lots of lectures on local anesthesia, medical emergencies, and I started surveying my audiences, and I could have an audience of 20 people or 500 people. And how many of you in this audience are either administering narcotics in your office or prescribing them? And the answers were very few. So I'm saying, why? And why on earth are we recommending you have naloxone, Narcan in the office? Well, let me go. I'll get to that in just one moment. But one of the reasons has to do with this. It's the way the medication is now available. When I did my anesthesiology residency, and Narcan, naloxone was a new drug, it was given intravenously. It was given intravenously or IM. But now it's available as a nasal spray. I mean, it makes it so much easier to administer this drug. It comes in a 2-pack. You use this medication the same way you'd use an Afrin nasal decongestant spray. So why? Well, this is an article, Jason Goodchild, Mark Donaldson, and myself published this article. It was published in General Dentistry about 3 years ago. And that's the title. Should naloxone be considered the next essential medication in the minimal dental emergency kit? And well, yeah, it should. And this is Dr. Art Pancioli is a physician, emergency medicine physician at the University of Cincinnati College of Medicine. This is an email he sent not just to me, but back in 2016, August 2016. Now, let me read it to you. Here in the epicenter of the crisis, 174 overdoses in our county in the past 5 days. We have had many odd stories of people shooting up in bathrooms of medical facilities, coming into doctors' offices high as kites, crashing cars in parking lots after passing out from shooting up. And he goes on to say, I would only advocate it, naloxone, because the use of opioids is absolutely everywhere. So this has been included. Go ahead, Don.
Let me throw this at you. So this is a quote from Dr. Pancioli, who's head of emergency residency, University of Cincinnati, incredibly credentialed, well-spoken. So I mentioned, hey, we've now included it in the kit, and Art said, you do know that naloxone in this format, when we're talking about Narcan, it can kill you. Needless to say, that blew me off my seat until he then followed up with, if you're hit by a truckload full of naloxone.
Okay,
so,
great.
And the key, just let me finish one quick point. So the key thing on this is, if you're thinking about this, if you see the lower respiratory state, whatever it is, do not worry about it, just administer it.
Absolutely. Absolutely. So what I'm showing you here is just the latest version of Health First basic emergency drug kit. And all the drugs that I've talked about thus far are included in this kit. And there's one more drug, and that drug is oxygen. And where I said earlier that epinephrine is the most important drug in emergency medicine, oxygen is number 2, but they're very different. They're very, very different. We need to have oxygen. We need to have a way of delivering the oxygen. You need to have, you see in the left-hand side of the screen, a portable oxygen cylinder. Now, there are dental offices out there where you have nitrous oxide oxygen piped into every operatory, which means you have oxygen available at every dental chair. But emergencies don't always conveniently happen with somebody in a dental chair. So you still need to have portable oxygen and the delivery system for it. Now, it says on the bottom here there are no contraindications. And without going into any kind of detail here, hyperventilation, which is essentially a panic attack where the patient starts breathing 30, 40, 50 times a minute, is a relative contraindication. In a hyperventilation situation, the idea is to increase the carbon dioxide level of the patient's blood. And we do that by having this panicking person cup their hands over their mouth and nose and simply rebreathe their exhaled air. Exhaled air has 100 times more carbon dioxide than the air you're breathing in. Now, if you were to give a hyperventilating person oxygen, pure oxygen, you're not hurting them, but you're not going to be helping them. So that would be the one contraindication right there. And as it says here, and I mean this sincerely, do not withhold oxygen from a patient during a medical emergency. As I just said, it may not make them better, but it will not make them worse. So let me then go on to a couple of more things, and that is equipment. We as healthcare providers still are trained to ventilate. In our CPR, we still ventilate. And there's not a person who's listening to this program right now or watching this program right now who, on a dental patient in the middle of dental treatment, could really want to put their mouth on that patient's mouth. So the next time you take a course in basic life support, a CPR course, my strong recommendation is you buy a pocket mask, a face mask for every person in your office. When the instructor comes into your office, I didn't mention that before, where to take a CPR course. Have the instructor come into your dental office, put the mannequin on the dental chair, put the mannequin on the floor in the reception room. Why? Because you are training your staff to handle a medical emergency in your office. So do your training in the office. Buy a mask for each person in the office. It will take not more than 5 minutes for that person to learn how to successfully ventilate with a mask. But let's go to the second really important piece of equipment. And I have been advocating this since the mid-1980s, automated external defibrillators. And I said defibrillators as in plural. Defibrillation in cardiac arrest, and let's admit it up front, a cardiac arrest can occur in a dental office. It is extremely rare, but it happens. It can happen. And by the way, it can happen not only to a patient, it can happen not only to the doctor or anybody in the staff. From the 2020 guidelines from the American Heart Association, I also have showing you here the European Resuscitation Council, defibrillation is critical if you want a person to survive a cardiac arrest. Basic life support and defibrillation, critically important. Why do you want two of them? And I've been advocating this for about almost 40 years. Let's take a look at this. So survival rates from sudden cardiac arrest. It's all about the return of spontaneous circulation, abbreviated as ROSC. And it's predicated on two things: survival to hospital discharge, bystander initiated CPR, somebody starts doing CPR before the ambulance arrives, and how little time elapses from that person's collapse until defibrillation. Also keep in mind, and here's the rationale behind my recommending 2 AEDs, 70% of out-of-hospital sudden cardiac arrests occur in the home of the victim. Okay, doctor, where do we, as dental doctors, spend our time? Well, we have a house, a home in which we live, and we have a place in which we work. And we spend most of our time in those two places. If you were to be the victim of a cardiac arrest, it is likely to be in one of those two places. So what I want you to do, and give serious consideration to this, is buy two of them. Buy two in theory for the office, but one is going to wind up in your home. Let's go back to why. Why at home? This is the chronobiology of cardiac arrest. Circadian rhythms. The peak in, this is a 24-hour clock starting at midnight on the left, going to midnight next day on the right. And the peak incidence of cardiac arrest is between 7 a.m. and 11 a.m. in the morning. And where are you? We're probably at home or we're in the dental office. So that's a very good reason right there, a good rationale for having at least one AED, but preferably two, one at home and one in your dental office. So let's then finish up and discuss the emergency algorithm. How do we treat a medical emergency? And this comes from the American Heart Association guidelines for CPR. Okay, we're going to go through this. This is the algorithm for all medical emergencies. Again, cardiac arrest is highly unlikely to ever happen in your dental practice, but this is the way we treat all medical emergencies. First step, properly position the victim. If the victim is conscious, any position they want. If the position is unconscious, right-hand side photograph, supine, feet elevated slightly. And keep in mind that the dental chair is perfect for this. On the left-hand side in green, conscious, comfortable, and we have angina, myocardial infarction, bronchospasm, hypoglycemia if conscious, and anaphylaxis if conscious. On the right-hand side in red, we have an unconscious victim, unresponsive to stimulation. We position them supine with their feet elevated slightly. What do we have? Syncope, fainting, seizures, cardiac arrest, hypoglycemia if the victim is unconscious, and anaphylaxis if the victim is unconscious. So there's our positioning, very first step in the management of all medical emergencies. Then we check circulation. Now, just keep in mind that if a victim is conscious, they're talking to you. Doc, I can't breathe. Doc, I don't feel good. We don't have to check circulation. We don't have to assess their airway or breathing, because just the fact that I'm talking to you right now means that my airway's open, speech is air coming out of my lungs, and I have circulation because I'm conscious. But in the unconscious patient, we have to physically evaluate each of these steps. We check the carotid pulse for not more than 10 seconds. If there is no carotid pulse, or if there's any doubt about there being carotid pulse, we start doing chest compression. Now, as you can see in the right-hand side of the photograph of this slide, yes, keep the victim in the dental chair. Taking a person who weighs, let's say, 200 pounds, dead weight, and placing them on the floor in a typical dental treatment room, number one, will be very difficult. And if that person is placed on the floor, there's probably going to be little or no room for you and somebody else to do CPR. So keep them in the dental chair. Then we assess airway and breathing. Well, in an unconscious patient, muscles relax. So on the right-hand side of the slide, the arrow, the tongue relaxes and the tongue falls back in the airway. The tongue is the most common cause of airway obstruction in the unconscious patient. And this step right here, head tilt, chin lift, you're probably going to wind up doing it sometime. And the reason is simple, because when somebody faints, you may hear them snoring, and snoring is indicative of a partial airway obstruction. And this step, left-hand side of the slide, you see hand on the forehead, a couple of fingers under the symphysis, the anterior part of the mandible, right-hand part of the slide, you simply lift. If you lift the mandible up, the tongue is attached to the mandible, and the tongue is now lifted off the back of the airway. And in virtually all situations with an unconscious patient, their airway will now be open. You assess breathing. If they are breathing, that's it. Don't do anything. If they're not breathing, then we put our face mask on and we have to ventilate that patient. Now we get down to D, definitive care, because positioning, circulation, airway, and breathing is basic life support. What we are doing is keeping that person alive. Definitive care. Can we make a diagnosis? If we can make a diagnosis and we have the appropriate drug or drugs in the emergency kit, we administer it. If we can make a diagnosis and the diagnosis is cardiac arrest, we have our defibrillator, AED. If you cannot make a diagnosis, then we pick up the telephone and we activate emergency medical services. So let me conclude just by repeating one more time. Our obligation to the victim is to try to keep that person alive until they recover, or until another more qualified person comes along and takes over their treatment. And the very first step in the management of all medical emergencies is basic life support, whatever steps are needed. So on the left-hand side of the slide, in a non-cardiac arrest emergency, which will be virtually all medical emergencies, position appropriately, assess circulation, assess the airway, assess for breathing, and then definitive care. Drug therapy always is secondary to basic life support. Again, there is our algorithm. So I want to show you this slide. This is a sheet, Don, what do we call this? It's a list of emergency medications and their indications. And this next one is a list of emergency situations, the most common medical emergencies, how to recognize, how to treat, and what drugs to use. So if you want a copy of this, I know there are a lot of you out there, but that's not a problem. If you want me to send you a copy of those two forms, the drugs and the emergency management, email me. My email is my last name, Malamed, at usc.edu. Okay, so with that again, Don, we have about 10 minutes or so, and I see there are some. Are you seeing the questions as well as I am, Don?
Yeah. So the first Q&A, and please, we're going to be, since we got 10 minutes, please feel free to log in on the Q&As. But the first one is really one of the best, and are most offices taking pre-op blood pressure? And I just look at that and it's like, God, I wish that were so. But recent studies have shown that is not so. It is so important that we recognize the value of doing that. And I'm not even talking about emergency medicine. Think of the fact that here's this patient who doesn't typically go to the doctor, and you're about to go through whatever procedures, whatever it is, you're in a dental office, anxiety's through the sky, and all of a sudden you're starting to see numbers of 200, 210, over 180. You'll thank anything out there that, God, I'm glad I didn't begin treatment and I got this person into some form of care. Stanley, why don't you grab the next one?
Oh, the next one is about the sublingual injection of Benadryl. The person wrote, it's very vascular and we are all familiar with the anatomy. Well, that second part is not really correct. Injecting a needle, putting a needle into the floor of the mouth, sublingual. Number one, the vastus lateralis muscle is more vascular. And number two, there is a lot of significant anatomy when you put a needle into the sublingual areas. That is not recommended. And I have never, ever heard anybody who recommends that. I know as a dentist, you may be more comfortable with this, but no, absolutely, please do not do that.
Let me go on the same scale. And this has to do with, again, a sublingual injection. Some places teach utilizing those same areas, the vascular areas, to inject flumazenil as a reversal agent after doing oral conscious sedation.
Mm-hmm.
If you read the IFUs on that package for the medication, specifically says this should only be used in a full running IV.
Right.
Meaning doing what you're doing there is, one, an off-label use, and two, probably won't be as efficacious as should be indicated.
And I'm going to
go ahead. No,
I am going to continue with that one because there are people out there who are teaching oral sedation and recommending the sublingual injection of flumazenil, and that is absolute idiocy. As Don just said, Dr. Cohen just said, what I call the drug package insert, it says very specifically that flumazenil is meant for intravenous administration only. Okay, and secondly, if you're using oral sedation properly, and most of you who are using oral sedation are using triazolam. If you're doing pediatrics, you're doing midazolam. And if you're using a benzodiazepine, which those two drugs are, the chances of getting a significant overdose with these drugs is minimal. But again, having flumazenil available is nice. However, the only what do you want to call it, route of administration that works is intravenous, because it works in 20 seconds. If a patient is overdosed on a sedative drug, benzodiazepine, and you give the drug sublingually, it's going to take 10, 15 minutes before it does anything. And if you're not doing other resuscitative efforts like maintaining an airway, by the time that drug works, your patient is gone. No, sublingual, no, don't do it. Don't do it. Don't even consider it. The vastus lateralis for the Benadryl and the epinephrine, absolutely, but not for reversing any sedative medications.
Next one for you. What about the use of bag valve mask for emergency situations?
Yeah, well, bag valve mask, also known as in quotes an ambu bag, which is a brand name. If you are trained to do it, I talked about purchasing a face mask. Well, a face mask, you attach this ambu bag device to it, bag valve mask device to it, but you have to be trained how to hold a face mask on with one hand, maintaining both an airtight seal and a patent airway, and then how to squeeze that bag. It takes a little bit of training. So if you're going to be a doctor who brings the instructor for CPR into your dental office, and I mentioned buying the face mask. Well, if you buy the bag valve mask, have that person train you how to do it. It's not that hard. It'll take a little bit more than the 5 minutes I mentioned to use the mask alone. But it's a valued way to go if you're trained to use it. So the next question, Don, why don't you answer that, is how much does an AED cost?
So I'm going to go real fast on that one. They can be anywhere from $1,200 or $1,400 to $2,500, depending upon the features you want. They're all FDA approved. They can't be sold unless they are. And you have to look at what features you might want in addition to just the AED.
Right. Next one was, go ahead, Don.
Go ahead. No, do it.
I thought compressions are not successful in a dental chair. Absolutely incorrect. And again, if you want, I can send you articles, studies that have been done going back to the year 2000, where CPR is very, very effective in dental chairs. I said earlier, let's say that I weigh 200 pounds and I'm dead weight. Getting me onto the floor is going to be very difficult, and there's little to no room for the rescuers to do CPR. The dental chair is absolutely appropriate for doing chest compression in an adult or pediatric patient.
Cool. Before we lose it, we had a request for your email again.
I'll go back. Let me go back. I don't know if they can still see the slides, but can they? Let's go. Where's my email address?
You can share your screen again.
I have to share it again. Okay. Share there. Share screen.
And by the way, if you want,
No, it's not working. But okay. So listen, for those of you out there, it's Malamed, MALAMED at usc.edu, as in education. Malamed, usc.edu. And I'm already getting lots and lots of messages here, so I have a feeling I'll be doing this for a while. By the way, I'm not going to do it right after we're done because I got to go eat dinner. I'm on the West Coast, but I will do this for you folks tomorrow. I'll send out the all the information that you're asking for.
One quick one before you get off, and that is for those two charts. If you go to healthfirst.com and go up on there, you'll see that you can find those two charts on there if you go to resources.
Good. That's even better. Okay. Now, for those of you like Ruth who said, can you send me the slides? I will do that. Will I ever have a nasal spray for epinephrine? Don?
Yes is the answer. Right now, one is being evaluated, and you'll see it probably over the next 3 to 6 months.
Great. Okay, so what time is it exactly right now? You have a minute or two left? You have actually 2 minutes. Let's see. Let me see. Local anesthetic overdose. Okay, first thing, don't. Okay, how about that? Don't. And how do we not have an overdose of local anesthetic? Well, number one, before every injection that we give, we always aspirate, preferably aspirate more than one time, and we inject slowly. Okay, intravascular injection is one of the two major causes of an overdose, but the by far major cause of local anesthetic overdose is the administration of too much local anesthetic to a young child who weighs less than 30 kilos. Unfortunately, in my career, I have been involved in the medical legal part of this with 27 cases of overdose in children. 26 of the 27 cases were a general dentist administering too much local anesthetic to a younger, lighter weight child. There's a whole scenario here. Again, if you email me part of the material, I'll send you, we'll discuss that. But locals are safe drugs.
So Dr.
But-
Malamed, last point on the overdose,
Sure.
because that can occur in adults as well. It's really
It-
important that you understand what the IFU, the instructions for use are on local anesthetic. Because I've given lectures, as so has Dr. Malamed, and we'll ask, how many carpules of, say, lidocaine red is it safe to give? I've seen numbers from 12 on down. So the answer
Yeah.
to it is, we need to understand how did that number get there and why. And that will keep our adult patients a lot safer.
Right. And again, adults, because of their body, okay, let me finish with this. One cartridge of any local anesthetic administered rapidly intravenously, guaranteed is going to produce a very, very dramatic, severe overdose. But again, the most common cause of this is injecting the drug properly, but simply putting in too much, not in an adult, too much in a younger, lighter weight child. So again, you've got to understand these drugs. I always start my lecture on local by saying these are the safest and the most effective drugs in all of medicine for preventing pain, with a little asterisk that says when used properly. So I think, Don, with that, I'm finished. Don, anything else you want to say?
No, this was great. Thank you very, very much.
Yep.
And
Hey, everybody who's out there, thank you very much for listening to us. And I hope we have a chance to do this again. Thank you.
Thank you.